Hey, welcome. We are so happy that you're here to hear Dr. Johnston discuss vascular surgery secrets for the attorney. I am pleased to welcome Dr. Johnston. Lily Johnston is a board-certified physician in vascular surgery as well as general surgery with over 9 years of experience caring for surgical patients. She specializes in operating on blood vessels in the neck and body, including aortic and other aneurysms, aortic dissections, peripheral arterial disease in the arms and legs, carotid artery and cerebrovascular disease, renal and mesenteric vascular disease, venous or vein disease, preparation and revision of vessels for hemodialysis exposure, and protection of vessels for spine surgery, vascular trauma or injury, and assistance with tumor resection when blood vessels are involved. Dr. Johnston received her BA summa cum laude from Princeton University, where she was inducted into Phi Beta Kappa. She received her MD from the University of California, San Diego, where she received an award for academic excellence. And after a residency in general surgery at the University of Virginia, she completed a vascular surgery fellowship at the Mayo Clinic. Dr. Johnston also received a Master's of Public Health at the Johns Hopkins University Bloomberg School of Public Health. Dr. Johnston has been awarded prizes for academic achievements at multiple institutions. She serves on the Quality Measures Committee and the Coding Committee for the Society of Vascular Surgery. She also served in a leadership position at the American College of Surgeons. She excels in her ability to communicate about complex medical issues with patients and providers in easy to understand terms, as you will shortly see. And she currently cares for patients in several area hospitals in both Northern and Southern California. So take it away, Dr. Johnston.
Thank you so much, Amy, for that kind introduction. And welcome to everybody. Good afternoon if you're on the East Coast, good morning on the West Coast. And that was a long list of things that I do. And I find that many people don't really understand what a vascular surgeon does. And that certainly applies to even people in the medical profession. So my job today is to give you a brief guided tour through vascular surgery and what an attorney really ought to know about the specialty and cases that involve the vascular system. So what I'm going to cover today includes just a brief overview of the vascular system, some common scenarios that I have seen working with attorneys and some cases. And then we're going to talk about a few special issues regarding vascular cases or cases that involve injury to the vessels. And then finally, I'm going to introduce you to a few current events that may prove interesting and provide some additional claims that may come forward in the future. And we'll have some time for questions and answers at the end. So let's start with just a brief overview of the vascular system. I'm going to do my best to avoid jargon, but I will also introduce some key terms or phrases that you may see as you review cases or claims. And I often joke with people that I'm just a fancy plumber. The vascular system is a series of pipes, and the fluid that runs within them, of course, is the blood. And that blood carries oxygen and nutrients to the organs and the tissues of the body. And the heart is the pump that pumps that blood through those pipes. So arteries are pictured on the little cartoon to the left of the slide. Those are always in red in any cartoon. They carry the oxygenated blood away from the heart out to the organs and to the tissues. That oxygen is delivered. And that's a high pressure system. The heart pumps, and the blood pressure, for example, that you measure in the clinic, that pressure is pretty high. And if there is bleeding from the arterial side, that is a high pressure leak in the system. Veins, after that oxygen is delivered to those tissues, the blood must return to the heart and the lungs to sort of refill itself. And the veins are always pictured in blue in these cartoons. There is also a secondary system called the lymphatic system that brings blood and fluid back to the heart to replenish the oxygen and the nutrients in that blood. Veins are a low pressure system, and that has implications for bleeding and control of bleeding when we discuss that in a little bit. But in general, bleeding from the venous system is very low pressure. Then people ask, well, what is vascular surgery territory? Where exactly in the body do you work? Do you do heart bypasses? Do you do brain aneurysms? So let's talk a little bit about where a vascular surgeon does and does not operate. The heart itself, and the plus is for the blood vessels that feed the heart, that is territory for cardiac surgery. Cardiac meaning heart, and they are responsible for the coronary arteries, which are the arteries that feed the heart, and they are also responsible for the very first part of the aorta. The aorta is the largest blood vessel that leaves the heart and brings blood to the rest of the body, and the very first part of that comes directly out of the heart and is cared for by cardiac surgeons. So really it's just that little yellow box that you see, that's their territory. Within the skull itself are obviously blood vessels. Those are typically cared for by neurosurgeons. So I can't operate within the confines of the skull, but right up to the skull base is fair game for me. The hand itself, so beyond the wrist, is cared for by a hand surgeon, which is typically an orthopedic or sometimes a plastic surgeon. There can be blood vessel issues within the hand, but that will almost certainly be managed by a hand surgeon. Everything else is taken care of by vascular surgery. So we operate from the base of the skull to the toes, and that is a pretty extensive territory. Now that asterisk is something we'll get to in a minute, because we are in fact not the only people who work on these blood vessels, and we'll cover that in more detail. But the point of this slide is just to enforce that we have a very broad territory we care for nearly every vessel in the body. And I think of blood flow as a Goldilocks problem, right? Goldilocks goes to get her porridge, and one is too cold and one is too hot, and the one in the middle is just right. And blood flow is very much the same way. And so we can think of blood flow as either too much, and that is a catastrophic bleeding problem, and sometimes the word is hemorrhage or exsanguination, or, that can be caused by a disruption or hole in artery or a vein. So the high pressure system or the low pressure system can be responsible for bleeding. Too little blood flow is a problem because the limbs or the organs that receive that oxygen from the arteries begin to die if they don't receive it. And that is a problem called ischemia, and that means lack of oxygen. And we'll come back to that term in a little bit. Ischemia is almost exclusively an arterial problem. There are absolutely consequences to lack of venous blood flow from the venous or vein system, but they are not typically emergent. And we can talk a little bit more about that in the question and answer if people have thoughts or concerns about that. But generally speaking, lack of blood flow is an arterial problem. Let's talk about how acute or emergent some of these problems can be. Too much blood flow, bleeding to death, hemorrhage, obviously that's an emergency. Too little blood flow, especially if it happens suddenly, is also an emergency. And we'll come back to the timing later, but this is something that if not addressed within a matter of hours, will cause permanent damage. Too little blood flow in a more chronic or a slower progression varies. That can be anywhere from an elective problem if the symptoms are mild, to an urgent but not emergent problem if the symptoms are more severe. And that is a clinical judgment. There are definitely guidelines that will help delineate whether these things are elective versus urgent, but it can have a time-sensitive component as well. What is important to recognize is that often the transition from trying to control emergent bleeding can result in too little flow. So in a heroic effort to save someone's life by preventing them from bleeding to death, you can unwittingly or even wittingly, but to do it to save a life, narrow or restrict the blood supply to an organ or a limb such that you have long-term problems with too little blood flow. We can talk about a case I'm reviewing that has a component of bleeding that was addressed, and then there was a lack of blood flow. That is a common scenario. Everything else in vascular surgery falls in the it depends category, and we're not going to spend too much time talking about that. But by and large, thinking about how emergent or elective a problem is can be helpful when you think about the case and the claim. As the next part of our presentation, we're going to go through a few common scenarios or even just categories of scenarios. And I think that putting things in categories helps conceptualize the nature of the claim and how to think about the case. So we'll go through the most common scenarios and how we can think about the injuries or vascular problems that are involved therein. So the first is a vessel injury related to an accident. And this can be everything from blunt, meaning a blunt force injury, or a penetrating, meaning a knife or a gunshot wound. And even a ground level fall can produce severe vascular damage in a vulnerable patient. The next big category is a vessel injury related to a procedure. So vessels can easily be injured during the course of a surgical or even an interventional, meaning a cardiology type procedure. And those injuries must be addressed in a timely and appropriate fashion. The next big category would be missed or mismanaged disease. So this can be the inadequate evaluation for signs of vascular disease. A patient comes in with discoloration in the foot and a vascular workup was not performed. That would be an inadequate evaluation. Or the patient has known vascular disease, but it's not managed appropriately. And this can be very subtle. We can go into that more in question and answer if people have thoughts about that. And then there's the everything else bin, which I would say is the minority of claims and cases, but compression syndromes, something called thoracic outlet, popliteal entrapment. The reason that this may come up is that these tend to occur in younger, healthier people who may have more disability related to an intervention or an operation. There are some rare syndromes, and then clotting and bleeding disorders can involve vascular surgery. I was reading a newsletter from a medical expert who says that anticoagulation or blood thinning related cases are some of the most common medical malpractice cases, and clotting and bleeding disorders can absolutely impact vascular surgery cases because most of our patients are on blood thinning agents of some kind. We're going to go into a little bit more detail about each of these categories. So accidents or trauma, this may be malpractice, this may also be personal injury. So a motor vehicle collision can injure the aorta. That's that largest blood vessel leaving the heart. That often happens in the chest. And the initial imaging for a trauma patient will often include a CT scan to look at the aorta. There can be damage to cerebrovascular vessels. Those are the 2 or the 4 vessels that go up in the neck, up and feed the brain. So the consequence of missing this could be a stroke. Those are also routinely imaged in trauma patients after a motor vehicle collision. Pelvic fractures with bleeding, another common scenario after motor vehicle collision. Falls with arm or leg fractures. The initial x-ray that I showed at the beginning of this section was a posterior knee dislocation. That's when the thigh bone moves behind the lower leg bones and the knee is dislocated. That disrupts the artery that runs right by that bone, and that can damage the artery and cause a sudden lack of blood flow to the lower leg and the foot. That's a vascular emergency, and that can be missed in the rush to fix the orthopedic or the bone problem. Knife or gunshot wounds, I think that's fairly self-explanatory. Industrial accidents can also absolutely cause significant vascular damage. In the realm of procedural vascular injury, the commonest case that I review is an orthopedic procedure with an unintentional vessel injury, and then what may or may not happen after that injury is addressed, which can be unintentional ligation of the blood vessel. Anterior spine exposure. So spine surgeons get to the spine a lot of different ways, but for some particular cases, they actually have to go through the abdomen or the belly to get there. And in that instance, the abdominal contents, meaning the intestines, are in the way. And the vena cava, or the major big vein that drains the legs up to the heart, is also in the way. General surgeons and vascular surgeons are often consulted to help move those things out of the way so that the spine surgeons can get there safely. There can be catastrophic bleeding or even exsanguination related to a tear in these vessels, and that can be a very serious situation for the surgeon and for the patient, of course. Other procedures with unintentional vessel injury. This photograph is what is called an angioseal. It is a device that is placed to close the hole in the artery that is made when interventional radiologists, vascular surgeons, cardiologists puncture the femoral artery in the groin. When they access that artery and they make a big enough hole, they do their procedure. Then at the end of the procedure, they like to put a closure device in that hole to stop the bleeding from the femoral artery and allow the patient to make a faster recovery. When it works really, really well. These closure devices, when they don't work, end up in the middle of the artery and blocking blood flow. And if that happens, then a vascular surgeon has to go in and fish it out and make a big incision and take the patient to surgery and all of these things. So that is a closure device that was inadvertently placed inside the femoral artery as opposed to outside the femoral artery, and required emergency surgery to go retrieve it. As long as it's recognized quickly, that is not grounds for any kind of claim or malpractice. But if it's not recognized, it can absolutely be a major problem. Missed or mismanaged disease. So chronic disease, which is limb ischemia. We'll talk more about this when we talk about current events, but this is a patient who has atherosclerosis, or the development of plaque that shows up in the arteries and over time causes this slow progression of lack of blood flow, and the foot or other parts of the leg begin to die. And that is one of those more urgent type of things, even though it has happened slowly over time. Abdominal or mesenteric ischemia. This is lack of blood flow to the intestines. This can cause profound weight loss and trouble with eating, and it can be a difficult diagnosis to make if it is not thought about by the original physician who evaluates the patient. Cerebrovascular disease. This is stroke related to buildup of plaque in the arteries in the neck. And again, this is something that has to be evaluated and managed appropriately to take care of the patients and prevent them from having additional strokes or stroke-like symptoms in the future. Kidney disease and dialysis access, obviously a chronic disease. The fistulas that are made in the arm for dialysis access, that's a vascular surgery procedure, and those have incredible amounts of blood flowing through them to allow the dialysis machine to work. It also means that those can cause significant trouble with the hand or catastrophic bleeding if there are problems with the fistula. Acute disease, missed or mismanaged. Compartment syndrome. This is the buildup of pressure in the muscles and the tissues, the soft tissues of the arm or the leg, usually following an injury. And this must be addressed within hours, again, because if that pressure builds up too much, that swelling builds up too much, it squashes the nerves, the veins, and ultimately the arteries, and causes permanent nerve damage if not addressed in a timely fashion. Acute limb ischemia. This is the sudden blockage of blood flow to an arm or leg or any organ. The picture down there is a number of blood clots that I removed from a patient who had severe COVID-related blood clotting disorder. And so all that clot in there was blocking the flow to her leg. And even just a small piece of that can cause catastrophic blockage and ischemia, but a large amount obviously is significantly problematic. And it's really making the diagnosis of acute limb ischemia that is the issue in question most of the time. Same for acute mesenteric. Mesenteric is the viscera or the contents of the abdominal cavity. This is intestinal lack of blood flow. Again, though that the small intestine will die within 4 to 6 hours of suddenly not having any blood flow. And that has to be a diagnosis that is made pretty quickly to get the patient appropriate, timely care. An acute aortic disease. So aneurysm rupture, severe problem, high mortality rate. and then dissection, which is a separation of the layers of the wall of the blood vessel. This can also be something that happens in a very sudden fashion. Patients present with pain in the chest, pain in the back, and those layers, when they separate, can block flow to organs or limbs, and that must be addressed in a very timely fashion. A few special issues in vascular cases to go over. The first is, don't blame the vessel for what happened nearby. So anatomically, arteries, veins, and nerves all travel together in what we call the neurovascular bundle. It's like a freeway or a highway system. You can see in the image that the red is the artery and the yellow is the nerve, and they're right next to each other. So if there is direct trauma to the arm or the leg, partly there can be a blood flow issue, but there may also be direct damage to the nerve. So this is when it's very important to get a detailed history and occasionally additional testing, for example, measuring the blood flow, measuring the conduction of the nerve, can provide some additional insight about whether ongoing symptoms or disability are related to the nerve injury or to the lack of blood flow. Vascular disease is a very high stakes game, and poor outcomes are not rare. This is especially true of vascular emergencies. Just as for instance, a ruptured aortic aneurysm carries about a 75% mortality rate. It means 3 out of 4 people who have a ruptured aortic aneurysm won't survive it. Other vascular emergencies don't have quite such high mortality, but rates of limb loss or severe disability are very high, even when everything goes well. Timing really matters for vascular disease. As we discussed, permanent damage from sudden lack of arterial blood flow starts at about 4 to 6 hours from the moment of that vessel becoming blocked. So getting that diagnosis and starting treatment in a timely fashion are critical to a good outcome for the patient. Chronic problems can also be time sensitive depending on symptom severity. So patients with chronic limb ischemia, lack of blood flow to the foot, for example, that has been progressing over months to years, can be time sensitive. If they develop a wound or a blister, an ulcer on the foot, that is a sign that the whole medical team needs to really get in gear and get moving. That is a time sensitive matter. And finally, context matters. Life over limb, always. So patients may be too sick to undergo vascular procedures. And I reviewed a case recently where a patient had a blockage of a vein in his leg, and there was discussion about trying to fix that. But unfortunately, he was in the intensive care unit. He was very sick. He had organs that weren't functioning appropriately, and the risks of trying to fix the blocked vein absolutely outweighed the benefits. And we just have to take the whole patient context into account when we're reviewing what is and isn't appropriate. So this is the asterisk when I mentioned earlier that vascular surgery territory is the whole body, right? Vascular surgeons treat this, but how many other physicians might treat blood vessels? The first vascular surgeon was board certified in 1982, but we have been taking care of blood vessels for long before that. And previously, vascular conditions were treated by general surgeons who included vascular as part of their scope of practice, and or cardiac surgeons who also dealt with the circulatory system. And both of those groups treated vessels pretty routinely. Since the 80s, vascular has been its own dedicated specialty with dedicated training. And vascular surgeons, of course, treat this system, but so do interventional radiologists. So do general and trauma surgeons still. So do cardiac surgeons still. Cardiologists also intervene on blood vessels routinely, both as a way to get to the heart, but also to treat vascular disease. Even kidney doctors or nephrologists who treat patients with dialysis can be involved in the creation of the arteriovenous fistula, or the access that provides easy access for the dialysis circuit. Lots of people are involved in the vascular system, which poses a little bit of a question for standard of care, because similar training or similar field becomes a little bit murky. Not all physicians have the same tools or technology. As a vascular surgeon, I do open surgery with a scalpel and a big open incision, just like you imagine. I also do endovascular or minimally invasive approaches, which involve a small puncture in an artery and work on the inside with X-rays, wires, catheters, and balloons. I can do both, but not all groups who treat blood vessels do both, and most don't. In rural areas, not all hospitals have access to a vascular surgeon. Vascular care may be provided by one of the other specialties that I mentioned, or they may have to transfer those patients to another facility to receive vascular care. And obviously, in these time-sensitive matters, that is certainly something to think about and be aware of when we talk about what resources are or are not available to help manage these patients. So what are some of the key questions that you can ask or think about when you are looking at a claim? For the treating physician, experience is a big deal. If they are not a vascular surgeon, if they are an interventional cardiologist or an interventional radiologist, how much of their practice is specifically treating vascular disease? How many of these cases do they do annually? Is this a small part of their practice and they're not maybe as expert as they could be? Or is this all that they do and they are absolutely a clinical expert in this? In terms of their education, did this physician undergo any vascular specific training, or were they sort of grandfathered in because they've been doing this for 45 years and this is all that they've done, but they didn't really have specific training? If they did have specific training, how long ago was that? What is the environment like in this particular facility? How are the vascular cases or complications usually managed here? And then the situation related to the case. When was the vascular problem identified? Was consultation with another vascular specialist considered, or a vascular specialist considered? And finally, hypothetical questions. If the treating physician is not a vascular surgeon, but you would like a vascular surgery expert to weigh in on this case, how can you get around this idea of maybe a different standard of care? Some of the ways to do that are some hypothetical questions. So I have been asked, are vascular surgeons commonly consulted for this type of problem? If a different physician injures a blood vessel and takes care of it themselves, great. But is that something that a vascular surgeon is called for? Yes, very frequently we are. How might treatment or the outcome have changed if a vascular surgeon had been involved, or if a vascular surgeon had been involved earlier? Would it have changed the course of treatment for this patient? And also, frequently the answer to that question is yes. Finally, does this client need long-term vascular care in the future? And that may certainly impact damages and disability going forward for your client. Briefly, I'm just going to talk about a few news articles that have come out in the last year. The first of these came out about a year ago and was in a publication called ProPublica, and they released this long-form article looking at the financial incentives that are related to a very specific type of vascular intervention called atherectomy. Atherectomy is basically a Roto-Rooter type of device that shaves or drills out plaque from the inside of the artery. And for policy reasons, it became very well reimbursed by Medicare and by other payers, and it became a little bit of a racket. And this article exposed a lot of that, and some of the practitioners, some of whom were vascular surgeons and many of whom were not, that benefited from overutilization or overuse of this technology for financial gain. Subsequently, about 6 months ago, the New York Times released an article discussing that when that technology is overused, there are risks associated with that, of course, and some patients, unfortunately, had very bad outcomes. They lost limbs related to the use of this procedure that may not have been medically appropriate for them. And because of these articles, there has now been a lot of press related to intervention for vascular disease. And as these publications have come out, there's been a lot of discussion about overutilization of the atherectomy technology as well as other devices and techniques. There has also been a lot of backlash about patients that lost limbs without any vascular involvement, and that is also tragic. So there are now lots of conversations and discussions about both sides of this. So you may see claims about patients who had atherectomy and may have been harmed by it. You may also see claims from patients who had bad outcomes from vascular disease, but didn't get appropriate treatment. So that's in the missed or mismanaged disease bucket that we talked about earlier. And both of these cases may have merit. So this has been a whirlwind tour of vascular surgery and what I think the general concepts that may be helpful for you are. Let me just wrap it up with a few key points to take home. So blood and the oxygen that it carries is essential to every single structure in the body from head to toe. Vascular surgeons, such as myself, we care for the vessels that carry that blood, and so we also work head to toe. Vascular problems come in many flavors, both sudden and chronic, and they all have the potential for severe complications, even when things go well. Many different medical specialists work in and around the blood vessels. Vascular surgeons have the broadest training and perspective, but a specific case, if the treating physician was not a surgeon, may require more than one expert to get a full comprehensive view of the case and what the options might have been. Finally, vascular surgery and vascular disease has garnered media attention quite recently, and this may result in some additional claims or cases crossing your desk. Thank you for your time and attention. I hope that that was helpful, and I would be really happy to take any questions.
That was awesome. Thank you so much. I definitely learned a lot. I also finally understand why I was checking limbs after cardiac catheterizations when I was a resident. So now I get it. Okay, I have a question from Attorney Pollack, who I'm going to actually allow him to talk so he can ask his question live.
Thank you for the presentation, very informative. You mentioned an atherectomy. What's the difference between that and an angioplasty?
Great question. Angioplasty is using a balloon to stretch out or expand an area that is narrowed in the vessel. So the plaque itself doesn't go away. It's simply stretched out to allow more blood to go past it. Atherectomy, as I mentioned, is a mechanical device. It's almost a rotor-rooter type of a grinder or a burr that shaves down the plaque. There are some others that are laser-based and so forth, but the plaque inside the artery itself is being removed or modified in some way by the atherectomy device.
And what causes sort of limb failure after an atherectomy, like you showed the lady in the wheelchair? Is that because the plaque is, released into the bloodstream and may be too large to pass?
That's a really important question. And sometimes we know and sometimes we don't. What I would say is that no vascular surgery intervention lasts forever. And the minute we intervene on a blood vessel, we can begin the process of the body's injury response. So when you remove a plaque, you can create a blood clot that can be sudden. Bits of that plaque that were supposed to be shaved off and sucked up into the atherectomy device can instead float downstream, as you mentioned, and sort of block off the little arteries that are further down towards the foot. That's called embolization. That is a known complication of atherectomy. But in more chronic cases, patients can have the atherectomy procedure, and then based on sort of maybe an overactive injury response, they develop even worsening narrowing in that same area as the body tries to heal what it perceives as an injury. So you develop new stenosis or new narrowing in that blood vessel as a reaction to the procedure. So part of the atherectomy conversation has been for patients who have limb-threatening ischemia, and for us, that is a specific set of criteria that define what is limb-threatening. Atherectomy is one of many tools that are important to try to restore better blood flow to the foot to preserve the limb. For patients who have less severe disease, so this is chronic disease that is in that elective category, we know that when we start doing procedures for those patients, we hasten their risk of limb loss. So those patients, many don't ever progress to limb-threatening ischemia. They stay as what we call claudicants, or patients who have cramping in the legs with walking. That is really inconvenient for patients, but is generally not considered limb-threatening. And when we start doing procedures for those patients, we accelerate the progression into limb-threatening ischemia, because these procedures all have risks. And so maybe it's the acute blood clot or the embolization problem. Maybe it is that the minute we start intervening, we set a clock for how long it's going to be before we have to do another procedure and another procedure and then another procedure. So it can be many different things, and it's going to be on a case-by-case basis to determine what led to the loss of limb or loss of function for that patient.
Thank you for that. Can I ask one more quick question? What type of physician is it that does the carotid endarterectomy? Is that a vascular surgeon or a cardiac surgeon?
Historically, cardiac surgeons did a very large number of carotid endarterectomies. They would be done at the same time as a coronary bypass in the heart. There are still some general surgeons who do carotid endarterectomies, and absolutely vascular surgeons do carotid endarterectomies. So it may be one of at least 3 different specialties or groups of surgeons who do those. Certainly it's an old operation. It's been around a long time, and you may find that the treating physician was any number of different specialties.
Thanks again. Thank you.
You're muted, Dr. Fogelman.
Thank you very much. Now we have a question from Attorney Avera, who I'm going to also allow to talk. Are you available to answer a question, Mark? All right, he might have stepped away. His question is, for those patients who undergo unnecessary atherectomy or angioplasty and suffer no acute adverse event, oh, here he is. I'll let him ask.
I had 2 unmute buttons. Thank you, Dr. Fogelman. Dr. Johnston, you mentioned we've seen quite a bit in Florida of with our retirement population of the unnecessary atherectomies and angioplasties that you referred to. But the vast majority of those patients whose cases I've looked at don't suffer any acute adverse event. They find out about it with subsequent treatment with another vascular specialist or interventional cardiologist, looking at old imaging that the procedure was never warranted. Is there any risk that those patients are exposed to having undergone an unnecessary procedure for which they have no acute adverse event?
We don't have a great understanding of that, is the short answer. They will need to be monitored for any progression of vascular disease in an ongoing fashion, and they are certainly exposed to risk at the time of that procedure. But if they, 6 months later or a year later, when someone else reviews their records, if they don't appear to have any adverse, suffered any consequences from it, I would say, the odds of them having a severe consequence of it further down the road are low. And you would be hard pressed to make a case to say it was from that original atherectomy, 12 months or 3 years ago that caused this. Somebody else on an opposing counsel will argue that, they have just progression of their native vascular disease, which is why they had the procedure in the first place and so forth. So, once you get past sort of a 6 to 18 month window, I think it's going to be very difficult to make a compelling argument that there is any lasting damage or consequence. That said, those patients will have to undergo surveillance for their vascular disease, but if they had the atherectomy, they had some vascular disease to begin with, almost certainly.
Thank you, doctor.
Does that answer your question? Was that helpful?
Yeah, I think so. It's
Okay.
a couple of these cases, there's little to no evidence of vascular disease, and that's why we're looking at it. But it's troubling, as you've explained, identifying what the damages are going to be for that patient, other than having to go through or having gone through the procedure, the unnecessary procedure.
Yeah, I agree.
All right, so I have a couple questions that I have of my own. So sometimes these cases have thousands of pages of records. So what are the key parts of the medical record that you need for at least a preliminary review if you're trying to facilitate, a timely and effective review?
Yeah, absolutely. What I really want are the consultation notes from the original presentation, or when the patient initially came in with their complaint, and what the history and the physical exam were, and that's usually in the initial consultation note. And then any procedural notes that are relevant, and then any imaging. So what CT scans, ultrasounds, those are usually the most important ones. What were those findings? If the actual images are available, that's even better, but the reports certainly will facilitate that initial review. And then typically the first, if the patient was hospitalized, about the first week's worth of notes from their hospitalization to understand, if there was a complication, was it identified and managed in an appropriate and timely fashion. So we can work with usually just that initial consultation, the imaging specifically, and then about the first week's worth of notes from the hospitalization. And often that will give us what we need for the preliminary review and can really get that case down to a manageable page number for an initial review.
Great. I also really appreciated you breaking down the different specialties involved in doing the vascular surgery. So can you explain a bit about the difference between vascular surgery and vascular medicine? And then also, are there any subspecialties within vascular surgery?
Vascular medicine is a specialty typically of cardiology or internal medicine, and they predominantly focus on very specific medical issues, often related to patients whose blood is too thick or too thin, they clot too easily or not well enough, or sometimes special lipid, meaning cholesterol type problems that can run in families or those types of things. That's really the vascular medicine side. Patients with vascular disease also should be on a number of medications, and their vascular disease should be managed medically. Most vascular specialists are responsible for that job for their own patients. So for example, if I am treating a patient with claudication, it is my responsibility, in my opinion, as their surgeon, to make sure that they are on appropriate medical therapy. So that includes a baby aspirin every day. That includes a medicine to stabilize the plaque and the cholesterol in their blood vessels called the statin. And so I wouldn't consult a vascular medicine doctor for that, but I am responsible for both the medical and the surgical management of their vascular disease. And sometimes it's the medical management portion that gets people into trouble. They weren't paying attention to the drugs that their patient was taking, or they didn't make sure to put them on the drugs that would keep their patient safe during a period of time while they were waiting for surgery, something like that.
Before you go on, can you explain claudication?
Yes, claudication is a pain in the muscles of the leg related to walking. There is a broader category called exertional pain. So you can get pain in even the arm muscles if there is a narrowing in the blood vessel to the arm. When people brush their hair or perform work up overhead, they can get pain, cramping in the arm muscles. Claudication is specifically the legs, but it is because the muscles aren't getting as much oxygen as they want when they're doing work. So patients will be able to walk 2 blocks, and then the thigh muscles or the calf muscles specifically begin to cramp. And usually the distance is very predictable. It gets better with rest. It's usually not positional. So sometimes people with back problems or spinal problems will also have leg issues with walking. It can be sometimes tricky to distinguish between them, but claudication is pain in the legs with walking.
Yeah, and I kind of think of it as angina of the limbs. So if you know that
Correct.
angina, that pain that one gets when they're walking, and it's because of their heart, that's what claudication is of the limbs.
Yeah, and I would say claudication is like stable angina, right? Claudication is typically what we consider mild disease. Now, for a patient, the experience isn't mild, and I'm pretty careful to express that, but claudication is not limb threatening unless it's to the point where they can't walk across the room. You know, if they are having trouble in their house with leg pain, that's more serious. But people who can walk a mile or even a block or two, you know, generally the management of that is an exercise program, and it's medical management, it's nutrition, it's lifestyle modification. We try very hard not to do procedures in those patients with this stable disease for the reasons that we discussed. That the procedures, based on multiple trials and a lot of published literature, the minute we start doing procedures, they run risks of transitioning into limb-threatening ischemia and higher rates of amputation.
And then subspecialties.
Subspecialties. There are not formal subspecialties within vascular surgery, but there are certainly areas of vascular surgery where people have focused a practice. And we discussed briefly thoracic outlet syndrome earlier, which is a compression of the nerves, the arteries, or the veins in the space between the collarbone and the rib cage. That's a fairly specialized type of operation. I don't do very much of it, for example, so I would never offer to review a case. I have several partners and people that I've collaborated with in the past who do a lot of that particular operation. They very much enjoy it and have focused their practice on it. So there are a few things that are a little bit more specialized, and people do have niches within vascular surgery. So thoracic outlet, for example, is one niche. And I would, certainly advocate for a niche level expert, to comment on that type of an operation. There are some aneurysms that are especially complicated. That would be another area where there are people who have absolutely focused their practice on exceptionally complex aneurysm disease. Those, would be the type of expert for that. There are also very much bread and butter aneurysms, and you just need somebody to take a quick look at it. And that's something that could be, identified in a quick 5-10 minute phone call.
All right, we have another question from Russ, and then I think we're going to this will be our last one. So here we go. Unmute yourself, Attorney Pollack.
You know it's a mistake to let me keep asking questions from previous podcasts, but we've got a case. It arises from a hospital, a tertiary care center. If the emergency department requests a vascular surgery consult because a patient has an ischemic hand that has actually a radial artery line in it, how long is reasonable for the consult to take to get there and to intervene? I know it's variable, but what's been your experience on how long that should all take?
Vascular surgery consultation within the hospital is difficult in the sense that vascular surgeons can be stuck in another operation. I have certainly found myself in that situation where I am called by the emergency department while I am actively doing another emergency operation, and I can't get there for a little bit of time. The hand has two blood vessels that feed it. One is the radial artery, one is the ulnar artery, and most instances of ischemia to the hand, the reason that they put lines in the radial artery is because if they mess it up or injure it, oftentimes the hand is fed appropriately by the ulnar artery. So that's a tough one because people might assume, having gotten that phone call, that the hand should be perfused by the ulnar artery and that there might be more time. But in general, any case of limb ischemia, somebody should be able to see that patient within a few hours or tell the ER, I am stuck in this awful emergency. I can't get there for several hours. If you are very concerned, you may need to transfer this patient to another center that can evaluate, or see if another specialist can evaluate. For a hand, maybe there's an orthopedic surgeon or a hand surgeon who's on call who might be able to come evaluate. That would be another option.
Thank you.
That's great. All right. Well, thank you very much, Dr. Johnston. Any last thoughts before we move on?
No, thank you for having me, Dr. Fogelman. I appreciate it.
Okay, so you can see how great she is. At High Rock Experts, we have access to over 5,000 experts like Dr. Johnston to help with your cases. And you know how crucial it is to find the right expert for your case. So please reach out to us if you need any help finding an expert. It's highrockexperts.com.